Okay, so let's start it. So we are going to talk about cardiac support and ionotropes. Before talking about cardiac support itself, let me talk about what organ support is. So in the intensive care, what we do is we are supporting your organs. So this is how the ICU differs from your normal routine ward setups. In routine ward setups, you are not able to provide organ supports, but in ICUs, we can provide organ supports. For example, a patient with a pneumonia, mild pneumonia, who doesn't have a respiratory failure, who doesn't have a problem in the lung, can easily be managed in the ward. But when they go into respiratory failure, so your lung is not working really well, you have to transfer this patient to ICU. And in ICU, we can provide ventilation for this patient. Therefore, the respiratory system is supported. So ICU is a place where we support organs. Similarly, when your kidney goes to failure, we can dialyze the kidneys, dialyze the patient and support the kidneys. So it's same for your cardiovascular system. Cardiovascular system, when it goes to failure, we can do various things to support the cardiovascular system. That is what we are going to talk about today. So before talking about cardiac support, what is the function of cardiovascular system? Cardiovascular system, the aim of the function of the cardiovascular system is to maintain adequate circulation to the tissues. So we are talking about the tissue level. So circulatory system is responsible to take blood from heart to your organs. So this is actually done by your heart and conducting system. And also then there is a vascular system, vasculature, and also circulatory medium, which is the blood. And blood is a different biological system after all, but the cardiovascular system comprises of heart conducting system and peripheral vasculature. And most of these functions are regulated by autonomic nervous system. So think about it. So you have a heart and you have a conducting system and you have a peripheral vasculature. So just recall your physiology from back of the day. You have a autonomic nervous system where you have a sympathetic and parasympathetic nervous systems. So actually you have a heart and conducting system which pumps, the heart which pumps, and this can actually be regulated by your sympathetic nervous system. So think about it. So, so your heart pumps at a normal rate and it pumps in the normal way, but when you got suddenly scared of something and your sympathetic system get activated. So what it does, it increases your heart rate, it increases your contractility of the heart, and it increases the blood pressure. So you can increases the circulation to the important tissues, like in that like when you want to run, so it will direct all your bloods to the muscle tissue by increasing your blood pressure. So think about it, and if we can control the autonomic nervous system, we can control your heart conducting system and peripheral vasculature as well. So all your ionotropes and all the drugs that I'm going to talk about, does these all their function through this autonomic nervous system. So they don't act like directly on the heart, they act on the heart and vasculature through your autonomic nervous system. So this is a very crowded slide. I don't want you to go through all of it. So here I'm going to talk about shock. So shock is a different topic. In fact, it's a different topic. So shock is actually, it's a syndrome resulting in an inadequate tissue perfusion and cellular oxygenation, which affect multiple organ systems. So let me go back, and your aim of your cardiovascular system is to maintain adequate circulation to the tissues. But shock is a condition where you don't have adequate circulation. So failure of the cardiovascular system leads to shock. So shock, you might have heard that it can be divided into various various types depending on the cause of the shock. So first one will be cardiogenic, and then distributive shock, hypovolemic, and obstructive. So think about a cardiogenic shock, where a patient getting a myocardial infarction or a heart attack, where there is a damage to the cardiac muscle, and therefore some of your heart muscles are dead, so they cannot function as the way that was before the cardiac arrest. So your tissue perfusion will be less because the heart cannot pump well. So that shock is known as cardiogenic. So next one is the distributive shock. Distributive shock is the maldistribution of blood flow. For example, septic shock and anaphylaxis. There is a maldistributions, like your blood should go to your brain and kidneys. Those are the important organs. But in case of anaphylaxis, it goes to your skin because there is like extensive vasodilatation. So it is not correct. So your brain will suffer loss of blood supply. So that is distributive shock. And then we come to the hypovolemic shock. Your heart is fine, your circulation is fine, but you don't have anything to circulate, like when there is a blood loss or fluid loss from your body. And last, the other one is the obstructive shock. Obstructive shock is also your heart is fine, your circulation is fine, but heart can't pump out because there is actually an obstruction to your outflow tract. So when you have pulmonary embolism, that kind of situations, you get obstructive kind of shock. So endocrine, which is actually rare, most of the classifications do not include this endocrine type of shock. So it occurs when their patients doesn't have enough catecholamines. Catecholamines means that is the neurotransmitter in the sympathetic and parasympathetic nervous system. So when they have lack of them, there is a shock. So think about cardiogenic, distributive, hypovolemic, and obstructive shock. Your pathology is different, but ultimately it leads to failure of your cardiovascular system. So let's again recall some of the physiology. So so you keep your blood pressure, the circulation, by maintaining adequate blood pressure. So blood pressure is, remember this equation, the cardiac output into peripheral vascular resistance or the systemic vascular resistance, and can again be divided into your cardiac output is actually the stroke volume into your heart rate. So your blood pressure will become like blood pressure equals stroke volume into heart rate into peripheral vascular or the systemic vascular resistance. So the drugs that acts to increase your stroke volume by increasing the contractility of the heart is known as the ionotropes. So ionotropy is the increasing of the contractility. So ionotropes are the drugs which can increase the contractility of the heart. And then we have the vasopressors. Vasopressors are the drugs that increases the peripheral vascular resistance. So what they do is that they go to your peripheral vessels, they constrict them, and therefore your blood will be squeezed from where they are, from the peripheries into the main circulation. So both ways we can increase the blood pressure of the patient. But these words ionotropes and vasopressors, they are loosely used, like almost all the drugs are called ionotropes. When you go to the ICU, we'll say start ionotropes, which means actually starting ionotropes plus vasopressors, or maybe vasopressors only, but still we call it ionotropes. But for the learning purposes, ionotropes are the drugs that increases the contractility, whereas the vasopressors are the drugs that increases the peripheral vascular resistance. But again, I'm reminding you, in the ICUs, everything is ionotropes. Okay, just I'm going through some of the common types of ionotropes and vasopressors in use. So you might have heard about this. So the ionotropes, actually, they increases the contractility of the heart. So you don't have to go into details, but in the heart there are basically beta receptors. So these drugs are beta agonists. So you have adrenaline, dobutamine, isoprenaline, and epinephrine. You don't have to remember all the drugs, but adrenaline and noradrenaline, the next vasopressor I'm going to talk about, those names, please remember, like in your internship period also, this is going to be very important. So you have ionotropes. One of the ionotropic drug is adrenaline. So then I'm going to talk about the vasopressors. Vasopressors are the ones which squeeze your blood from peripheries into the central circulation. So there you have the noradrenaline, and one of the important drugs is this noradrenaline. So how noradrenaline differs from adrenaline? It's very small difference in their structure, but adrenaline acts on beta receptors mainly, whereas noradrenaline acts on alpha receptors. Alpha receptors are abundant in your peripheral circulation. So that is why this becomes a vasopressor, and this is actually more inotropic. And then there are drugs called ionodilators, which has a different action. They increases your contractility, but dilate your peripheries. These are very expensive kind of drugs, and these are used in very different situations, like in cardiothoracic ICUs. And levosimendan, this drug we don't actually have in most of the ICUs, but milrinone we do have. And then there are some other agents like dopamine, which doesn't really fit into any categories easily. This drug actually, of course, don't use in most of the hospitals, most of the other countries, but we still have it, so we use it. So remember the drugs adrenaline and noradrenaline, and also remember dobutamine. I'll tell you why. Dobutamine also an inotropes, so other than adrenaline. So I'll tell you why this is important. So this is actually too much information. I'm not going to go to too deep into each kind of inotropic agents. So first I will talk about the important ones: the adrenaline, noradrenaline, and dobutamine. Okay, so adrenaline, they're all catecholamines, just don't worry about it. As I told you earlier, they act mainly on beta receptors, but they do have some alpha effect as well. So adrenaline, they increases the contractility. Okay, one of the most important use of adrenaline is that it's being used in cardiac arrest situations. So once you finish the final year, before you go into the internship, you will have a training session on how to give CPR to patients, like advanced life support. So the main drug that we used in cardiac arrest situation is the adrenaline. So what it does is that when you give it in very higher concentration, it increases the contractility, and also it increases the vascular resistance in very high circulation, concentrations. Therefore, it is an important drug in cardiac arrest situation. So remember that. And the other important thing that this is used is in situations of anaphylaxis. Anaphylaxis is also a common complication that can happen in the ICUs as well as in the wards as well. They can have anaphylaxis to various drugs in ward setups. So you have to know the drug of choice for anaphylaxis is also adrenaline. So in addition, yes, adrenaline is used as an ionotrope in ICU setups. Then we come to the noradrenaline. As I told you, noradrenaline, the action is mainly on alpha receptors rather than beta. So alpha is your peripheral circulation, and it increases your peripheral vascular resistance. So this actually is the drug of choice for conditions like sepsis. So you have heard about sepsis a lot. So sepsis, in sepsis, there is a vast peripheral vascular dilatation. Peripheral vessels are all dilated. So what you need to do is you have to constrict them. So noradrenaline is one of the drugs that we can use very commonly, which is actually the drug of choice. The first line of drug is noradrenaline to use in sepsis. So adrenaline in cardiac arrest and anaphylaxis, and noradrenaline in when the patient is sepsis. So dobutamine, so I'm going to avoid dopamine because it's not widely used. So dobutamine, it's a synthetic kind of a drug. So it again has beta activity, and it increases the ionotropy. So why I'm telling this is important is that, so all the other drugs like adrenaline, noradrenaline, just forget about dopamine, all these drugs, for them to give, we need a central venous line. I hope you know what a central venous line is. So you can't just give these drugs from your peripheral circulation. Why? So think about noradrenaline. Noradrenaline is a very potent drug, like a very strong drug. So if you give noradrenaline to your central vein, so what it does constrict the vessels. So when it goes through the vessels, it will start constricting the same vessel. Therefore, those vessels will go into ischemia very easily. Therefore, we do not use noradrenaline or adrenaline from peripheral lines. But dobutamine is not like that. Dobutamine can be used from the peripheral lines. So when you're working in the both setups, you may not have skill to put the central venous line at first. Therefore, you can start when the patient's blood pressure is low, you can start the patient on dobutamine until you get a central line in. So those are the three important drugs I want you all to remember: adrenaline, noradrenaline, and dobutamine. And then the other drugs are vasopressin, levosimendan. I said this is not widely available in Sri Lanka, but milrinone we do have use it in cardiothoracic ICUs. So just remember all these things, and there are some cautions when we have to go under, like adhere, when we are giving ionotropes to patients. So all these drugs, their half-life is very limited, like very short half-life. Half-life is like some of the drugs, it's seconds. So if you give the drug, once it before it goes to the site of action, it may be deactivated. Therefore, you can't give like adrenaline 3 times a day like that. Those drugs are not given like that. All these drugs has to be given as infusions. That means it's it will goes to the patient as a continuous dosage of drug. So continuously the drug will be going to the patient. So the ionotropes has to be given as continuous infusions, and there are special infusion pumps to give these kind of infusions in ICU. And the next one I have told you all before this also, most drugs has to be given via a central line, not through a peripheral cannula. So dobutamine can be given through a peripheral cannula, but not the other drugs. And when we are giving these drugs, not like the other ones, we have to do frequent monitoring and adjustment of doses. For example, when we are using vasopressors, some patients respond very quickly. When you start noradrenaline, they will quickly respond to it and blood pressures will shoot up, and that is not good for your patient. Therefore, monitoring is necessary. So I know you all are tired, but as a take-home message, just remember when your patient is having a low blood pressure depends on your stroke volume and systemic vascular resistance. All you have to do is to increase either of these. So if you're thinking about hypovolemia, you can give it adequate fluid to get your blood pressure up. But if it doesn't work, that means there is something wrong and the patient is in some other kind of shock, not just a hypovolemic shock. So in that kind of situation, you have to think about increasing stroke volume by using ionotropes or increasing peripheral vascular resistance by using vasopressors. And drugs that we are going to use are first line in most of the cases are noradrenaline, but you need a central line for that. So until that is available, you can start on a dobutamine through a central peripheral line. And also adrenaline, don't forget in your cardiac arrest situations and anaphylaxis, and then noradrenaline in your septic shock. And everything has to be given through a central line as infusions with frequent monitoring. So those are the important things I want you all to get into your heads. So thank you, and that's all I have to say. And if you have any questions, I'll give you like 5 minutes. I know all of you are tired, so you all can ask. Okay, it's late also. If you don't have any questions, we'll wind up from here. And thank you for listening. Sorry. Madam, what is the difference between Chronotropes. So chronotropy is chronotropy is your increasing your heart rate, right? Chronotropy. So inotropy is increasing your contractility. Chronotropy means increasing your heart rate. But there are no drugs class called chronotropes, but drugs which has the ability to increase your heart rate will be known as chronotropes, right? So, but there are no drug class, so all your ionotropes will invariably increase your heart rate as well because they act on the similar receptors. Hope I answered that question. Okay, if there are no other questions, I'm going to... so, madam, is there any place for inotropes in heart failure? Yes, definitely, because heart failure is one of the failures in your cardiovascular system. Okay, your heart failure occurs mainly following myocardial infarction. So when you have a myocardial infarction, as I told you earlier, part of your heart died, not like even a small part. Until that part recovers, some parts, they go into a state of non-functioning state for a shorter period. And for that, until that recovers, you have to support the patient. So ionotropes are indicated in heart failure. Okay, so so it has to be ideally an ionotrope. So our drug of choice would be dobutamine. Okay. Or adrenaline. But the problem is these two they cause tachycardia. Okay, so we have to titrate. Tachycardia is not good for heart failure. So we have to titrate the doses of inotropes when we are using in heart failure. And in most of the ICUs, you will see the first drug that they are going to start is noradrenaline. Okay, but I told you noradrenaline is a peripheral drug that increases the peripheral vascular resistance. So it doesn't cause your heart to pump better, but it feels like this doesn't match. Like we need something to increase your contractility in heart failure, but we are actually giving something that increases the peripheral vascular resistance. So so this is because your heart is supplied, blood supply to your heart occurs during the diastole, and this is like a little advanced stuff. So your blood supply to your heart occurs in the diastole, and your diastolic pressure depends on your peripheral vascular resistance. So when you increases your peripheral vascular resistance, when you increases the peripheral vascular resistance, what happens is it will increases the blood supply to your heart as well. So both ionotropes like dobutamine and adrenaline and also noradrenaline are used in heart failure. Okay. The next question is in anaphylactic shock, where there is peripheral vasodilatation also. So why can't you use noradrenaline? Very good. That's a very good question. So anaphylactic shock, so it's an actually undistributed type of shock. And in addition to that, the pathology is there is mast cell degranulation, releasing histamine, causing this vasodilatation. So adrenaline also has an effect on reducing this mast cell degranulation. So that is one reason why we use adrenaline in there. And also, initially we were using noradrenaline for patients who have low blood pressure after anaphylaxis, but research has shown noradrenaline is better than noradrenaline in managing anaphylactic shock. That is why. In ward class, we were told that the ionotropes are drugs that manipulate contractility and are positive and negative ionotropes. We weren't able to clarify that statement. So yeah, so ionotropes are usually drugs that has effect on the contractility. That's true. And you have positive and negative inotropes. So if you have positive inotropes, that should actually increases your heart, the contractility. Negative inotropes are drugs that reduces the contractility. But we don't use negative inotropes because we don't want your heart to contract less. Okay, so we only use positive inotropes. Therefore, your drugs are known as inotropes, not as positive inotropes, because we don't have negative inotropes. I hope I answered that. Yeah. Madam, in cardiogenic shock caused by MI, if you use adrenaline, it may worsen the MI. Yeah. So adrenaline is it has a positive inotropic effect, and same time it will increase your heart rate. Okay, when you increases the heart rate, it is not good for your heart, because when it's pumped in like 120 rate, you don't your diastole shortens. So in the diastole only the blood supply to the heart happens. So you should never allow the patient to go into a tachycardia while they are on they are having heart failure. So if you use adrenaline, yes, they should go to a tachycardia and worsen heart failure. That is true. That's why I said you always have to titrate. And I told you earlier, so when you use adrenaline, and also you can use noradrenaline in this situation as well. So your noradrenaline, other than increasing your peripheral vascular resistance, it will cause a reflex bradycardia. So your noradrenaline will cause a bradycardia as well. And if you use noradrenaline, and we commonly don't use adrenaline, mostly using dobutamine. So if you use dobutamine and noradrenaline, you can titrate the effects. So you can increase the norad and increases the blood pressure, and which will reduce the heart rate, and your dobutamine will increase the contractility, but the effect of noradrenaline will be more, therefore you won't get the tachycardia. So that's how we are as I told you, we are going to titrate. Okay, it's always remember, all these drugs we are monitoring very, very closely. These patients, their heart rate going up is not good at all. Therefore, we try to balance the situation. While increasing the cardiac output, we have to control the heart rate as well. So basically, you have an idea about what is an ionotrope and what is a vasopressor means. But in ICU or in the ward, everything will be known as ionotropes. So start ionotropes, that's what your senior is going to say. මෙයාගේ blood pressure වැඩි වෙන්නේ ionotropes පටන් ගන්න කියලා තමයි කියන්නේ. ඒක එයා mean කරන්නේ vasopressors වෙන්න පුළුවන්. ඒ කියන්නේ වගේ noradrenaline පටන් ගන්න කියන එක උනත් වෙන්න පුළුවන්. What he means. So everything is ionotropes in ward setup and also in ICU, right? So you have to think about the indication why the blood pressure is low, and depending on the indication, you can use the correct drug. And you can always ask the ICU for help until your ICU bed is available. You can always ask the ICU for help if you are in doubt what drug to start. Okay, so don't forget adrenaline for your CPR, cardiac arrest, and also for anaphylaxis, they are drug of choice, and noradrenaline in sepsis. Okay, if there is nothing else, so okay, then thank you for listening. So I'm going to stop it there, and thank you.
Thank you very much, madam.
Okay, thank you.